Thank you, Ian, and good afternoon, everyone. We're going to run this like one of our podcasts, so just in case you're wondering, you should feel like guests in our studio audience. And like our Simulcast podcast, we're going to have some interview segments, and then at the end we're going to have one of our famous Journal Club sessions. So you're ready to come in-roll now? It's kind of like we're about to start, the camera's rolling on Ellen. Good thing. Okay. Welcome to Simulcast. I'm Vic Brazil, and I'm here today with Cara Allen to talk a little bit about the place of simulation, and in particular to think about some of the bugbears that some of us have when we're in the business and we think, really, should we be doing it this way? So I'm going to introduce my guest first. I've got Dr. Cara Allen with me here today. She is a specialist anaesthetist. She works at the Royal Melbourne Hospital, and perhaps more importantly for today, she is the medical lead at Monash Simulation. She teaches in a lot of those courses that have clever acronyms, some of them to do with anaesthesia, some of them to do with more general training. And how are you, Cara?
Use the microphone. I'm well, thank you, Vic. Thank you.
Yes, one of my jobs here today is to correct her microphone technique. I know you're excited to be on Simulcast, and in fact, it's not your first gig here, but I thought today we're going to talk a little bit about, you know, the things where, sure, we're enthusiastic about sim, but as you and I know, there's some things that just don't quite sit right with us. So I thought to kind of get us in this conversational mood, I might give us a sort of typical case. So let's say you and I we're clinical educators, and we've been asked to do some stuff over in the sim centre. And this has kind of been prompted by the people who look after the quality and safety. They want to tick off standard 8 about recognising and responding to clinical deterioration. And we've got a lot of junior doctors who kind of want to do more sim in their term evaluations. And so we've been asked to put together this program around deteriorating ward patients, hypotensive emergencies. Of course, it's got to be interprofessional, so we're going to get the nurses there too. We've got some mannequins, we've got a few people. So, I mean, let's just sort of start. How are we going to set this up? How do we even feel about putting this together?
Yeah. So I love the description of do some stuff. And ideally, if it could start tomorrow, that'd be fantastic. And if it could just address all these things, and we have this problem too. So, you know, if you can sort of sort that out while you're there. So those of you that are doing sim, particularly in situ sim, you'll often sort of get that kind of brief, I think. And I think that's such a great description, because sometimes when people come to you with a problem, they think simulation can solve it, but they may not necessarily know that much about sim. So the first thing is that I really want to get a clear picture of what it is that, I mean, with the description that we've got from this case, it says a lot of things. You know, we need accreditation for standard 8. The junior doctors are saying they want to do more sim. We want to get the nursing staff involved who might want to do some team training. So those are 3 pretty big objectives, and they're great objectives. You know, there's nothing wrong with them. But breaking each of them down, there's a few little things that kind of send up little yellow flags for me. You know, we were talking earlier about this idea of doing sim because they like it for the junior doctors. So why is it that the junior doctors want to do more sim? Is it because they actually like the experience of simulation? And that may not be a uniform thing amongst the junior doctors. Or is it because they're actually struggling to get the clinical exposure in that department? So I think that's a really important question in terms of thinking about what we're going to target at the learner level.
Yeah, and I guess let's drill down on this. I mean, I suppose there's nothing innately wrong with liking it as a reason. So then how do we manage their expectations if we're not necessarily going to do, I don't know, a thoracotomy for the interns? You know, because they want to, and they might have to do it one day. How do we kind of frame it back to something that we think is going to be useful, like we've seen, having a talk to a parent of a child that even has just broken their arm?
Right. Or even like what Warwick was saying about the 7-year-old doesn't get to decide whether or not they're riding the booster seat, you know. I mean, our agenda
I like
matters.
your analogy
yeah,
for junior doctors, yeah.
I mean, they're not 7, they are grown-ups, but our agenda matters as well. Like, I think the learner agenda, we're very learner-focused. We do want to target the learners, A, where they're at, and B, what they're interested in. And sometimes I think that's one of those things that can get a bit out of control when we're running simulations. But doing sim because they like it, as Vic says, is not a terrible reason for doing sim. You know, it can increase engagement, it can increase morale. You know, there's lots of really great reasons for doing it because they like it. But in terms of targeting it where they really want it, I think that does have to be a balance of, what's happening in the department generally, what's the zeitgeist, and what do the individual learner groups want. And if you're talking about interprofessional sim, that's quite a lot of learner groups to address.
Yep. I just love it when we get zeitgeist out early in the podcast. It's important to realise the kind of thing we're dealing with. For those of you who've just joined us, welcome to Simulcast. I'm Vic Brazil. We're interviewing Cara Allen here today. And we're talking about the place of simulation in all our healthcare training. So, okay, that's a nice point of departure, I think, onto the interprofessional issue, because I think you've said, sure, we can design sim around but we also have to fit this in with, a bit more, I guess, rigorous needs analysis. And one of the needs that people are telling us is we've got to train doctors and nurses together. And I guess I'll go out there straight away and say I've seen a lot of sim where the nurses get dragged along, but really everything ends up being about the doctors. Can you give us a little sense, like what's the alternative? How do we make something really interprofessional?
Yeah, I think that's a really important question, and it's one that I've sort of turned over quite a few times, and it depends a little bit on context. So, there will be different needs in a paediatric emergency medicine unit versus a paediatric ward versus palliative care. You're going to have different perspectives, and from my point of view, the gold standard is always getting people from each interprofessional unit that you're hoping to engage with as part of development of the sim itself. So thinking about what the learner groups are likely to want and need, and what the learner groups, how the learner groups are likely to respond. So what do we have to do to provide the nursing staff with an opportunity to do their best work in the simulation, because that's a really important part of doing a simulation that's really meaningful to them. And often one of the things when we do sims in the sim centre, which is mostly where I'm based at the moment at Monash, is that the nursing staff don't know where the equipment is. And that's a really destabilising thing for them. And no matter how much we sort of familiarise them to the environment and talk about what's in each drawer of the trolley, sometimes it doesn't look what their department looks like. And that's a really destabilising and upsetting thing for them. I'm not saying that it's not something you can't overcome in the debrief, but you really need to think about it. I think it's easier for somebody who does that sort of work to think about it than it is for me as a anaesthetist clinician. I can't put myself in the head of a paediatric emergency medicine nurse. I can't do it. So I need somebody who's got context expertise to be able to help me with that.
So it sounds like there's sort of 2 points from there. One is you can do anything, but you can't do everything. So the same sim won't necessarily get your teamwork outcomes as well as your let's go through the pharmacology of induction agents. Right. But also I think you're saying is that in the both design and I suspect in the reflective conversation, you've got to have that other professional, the other perspectives, whoever is in your group. Yeah. And that's quite hard to do. I mean, it sounds like even at this design phase, we've been told, you've got some non-clinical time, Cara and Vic, so you can go and organise it. The poor nursing staff don't. How do we kind of get around that?
Yeah, so I think that is really tricky, and I think sometimes I'll use conversations on the floor to sort of engage with people who seem to be really interested in that. And you may be able to identify people in your department who are interested in quality improvement who may not necessarily have an educational background. I think those people are amazing resources because they actually do care about what happens to patients, not only in their department, but maybe when they leave the department. And they're also engaged in that process of, modelling and providing really good teamwork as well. So they're great people to have involved in the development of the sim. And there are also people to ask about how they perceive things like teamwork, working on the floor, because, as I say, even if they don't have educational expertise, they have that expertise of being that clinician who's experienced good and bad. And I think that's somebody who can really give you some points to hone in on when you're developing the sim.
All right, so we're sort of going through our design and delivery stage, and Ben may or may not have some comments for us yet, but I get the idea this is where we're up to. So we've been given this mandate to do it. We're definitely going to go into professional, knowing though that that's probably going to narrow our focus of content a bit. Yeah. We're going to match up what people want to do with what we think will be good for them, because probably we should. And I guess we're going to probably start to really think about this as not just education, but quality improvement as well. Ben, any comments, thoughts or questions from our audience?
So we've just got more enthusiasm for the session rather than specific questions at the moment.
Oh, well, that's good too.
What we should have mentioned at the start is my Twitter handle is @PedsEM if you have any questions, so send them my way.
All right, thanks very much, Ben. Okay, so we've been through the design phase and now we've got some learners in the room with us, and I wanted to turn our attention now onto this whole idea of pre-briefing, because we're there now. We're going to concentrate on the delivery phase. And, it's one of my both favourite things to talk about, but also least favourite, is the psychological safety in the room. And you kind of get the idea, we're in sim now. Quick, let's do a little kumbaya. It's all safe here. It's all safe here. It's all confidential. Yeah. And honestly, I've got a bit of an allergy to it now.
Yeah.
But tell me, how do you actually do it?
Yeah, so I think I don't want to get too ahead of the vulnerability aspect of it, but one thing that's really helped me personally is thinking about having a conversation with people and learning from them at the end of it. So the idea is not that, I'm here as an expert on how things work in your unit. The idea is that I'm going to learn things from you and you're going to learn things from me. And also giving myself permission not to fix everything in the sim today. Because if I'm putting that pressure on myself when we go in, then I am going to be a bit stressed, and that's going to come across to everybody in the room. So some of it is about my own attitude and how I approach it. I really, like Vic, I kind of object to people saying, well, this is a safe environment, because just saying it doesn't make it so. If you're about to say to a kid who you're about to stick a needle in, this isn't going to hurt, the kid's looking at the needle and they're looking at you, they do not trust you. And plenty of people have had bad experiences with sim where it has hurt them or where they haven't felt safe, and so they're bringing that into the simulation with them. So I think acknowledging that, and I think also acknowledging that learning can be uncomfortable and painful. And we are going to be learning some things today. That's kind of the aim. I'm going to be learning some things from you. You might be learning some things from the simulation, hopefully. But the idea is that it may push us a little bit outside of our comfort zones. And the more willing we are to engage in that place, the more likely it is that we actually will take something meaningful away from it.
And I know our next episode has got something to do with vulnerability, but I think the other thing is we probably have to cut ourselves some slack in terms of the time. Like, we probably aren't going to achieve nirvana in psychological safety in our first run through with this. Because people, as you say, they've got a lot of baggage to it. We're not trying to send the message that this is all going to be lovely, but rather it should be safe enough to take risks.
Right. One of the other things that I've been thinking about is how much to disclose to the learner. So, do we say, this is going to be a simulation about malignant hypothermia, if it's anaesthetics. The point of this simulation is not so much to determine whether or not to give dantrolene to a patient that's having malignant hypothermia, but is that easy, and what are the challenges in doing that? And then that really sets the learner up to go, okay, so it's not about whether I know this stuff, it's actually about how can we as a group do it. And I think if that's your goal, why not say that to the learner? What's the disadvantage?
And I think I've had some interesting conversations with people about that, because for our simulations, we send out pre-reading that says stuff like ectopic pregnancy. So there's no secret when you get there that when you're going to have a young woman with rhodolic fossa that's what you're going to be managing. Because like you, I don't think sim's very good for learning cognitive stuff. I think it's fantastic for thinking, if I know I have to get to the operating theatre and do a blood transfusion and explain to the patient in real time what's happening, can I make it happen?
Right, absolutely.
But I think people hold on closely to but we're going to trick them. We're going to get them. We're going to test them. How do we, because that then leaks out this whole psychological safety.
Right, yeah. And I think that is important, because sometimes I think we do that without meaning to. So, we set up, I've definitely run simulations where people have reached the wrong conclusion. Sometimes it's a great indication as to whether or not they've read the pre-reading. But I have definitely run simulations where, somebody has reached kind of like the wrong diagnosis, and it's been a little bit problematic in the sense that it's kind of derailed the sim a little bit, because the rest of the team might be going, we read the pre-reading and it's ectopic pregnancy, it's not appendicitis. So that's where the topic, the debrief, you have to have that flexibility to turn on your feet a little bit and acknowledge, we weren't trying to trick you, but we're human beings and we make mistakes. And that's, again, where I think that vulnerability comes in. Not, I knew it was ectopic pregnancy and everybody else knew it was ectopic pregnancy. What's wrong with you that you didn't realise this, sort of thing?
It's also feedback for our simulation design, isn't it? Because obviously we've got the signal and noise wrong, and I think that's one of the interesting issues in delivery is how you manage signal and noise. And I think it's actually really hard. Like, we have to send strong signal usually if there's a diagnostic issue in a sim, because so many other clues are missing.
Yeah, and I think when you're talking about looking at somebody who feels that they've been tricked, that is a legitimate point of view, and it's challenging to me personally as an educator to address that, but I need to look at that and say, okay, what about the simulation that I provided, what about the way that I wrote it, what about the way that I delivered it resulted in this person having this response? Because, you know, the learner-centred approach says that I'm providing them with noise that suggests that the signal's wrong. So it's legit that they feel tricked.
All right, well, keeping our attention on the behaviour of our learners in sim, one of the things that I think is quite hard is that, again, people come to this idea with a preset idea about sim and they think, right, shortness of breath, something terrible is going to happen. Would you just draw up the induction agents, please? And, you know, immediately people start frequency gambling, to use Jessie's term, about what's going to happen and get ready for that. And so they start performing rather than truly practicing. Strategies for sort of getting around that?
Yeah, I think for me, I was saying to Vic, this is one of the hardest things in terms of, you know, I know that people are performing in a sim for the most part. Like even when they're really well bought in, you know, they appear to be immersed, for want of a better word, I know there's always going to be an element of performance and they know they're being watched. And for some people, I think that completely prevents immersion. So they will just be performing and then they'll know that they have to talk about it afterwards. So I think when you're in the debrief, I think it's okay to acknowledge that and say, you know, okay, so there's always going to be some things that don't happen the way that they happen in real life. So you can say, let's get them out of the way first. You know, so what were the hang-ups? What were the challenges? What did you think happened in there that wouldn't happen in real life? And that's a completely reasonable thing to do, and that can really help clear the air. Sometimes that's a little bit of a value judgment to call for the group and determine, because there might be one person who's like, no, I was totally in that. Oh, that was real, you know, and everybody else is like, okay, so that felt a little fake. But there's also a degree to which it's, you know, some of the things, like if we're dealing with emergency situations, then they will never have done this. And so, or they may never have done it. And so there is going to be that element of performance because this is a new thing. And so they're sort of self-discovering how they behave in that situation. And so I think that's a debrief to handle quite carefully as well, because that can be really confronting for people to have a look at themselves in a situation and go, wow, I didn't do what I thought I was going to do. And, you know, we know from educational theory that knowing how and doing and showing how are completely different things. So taking people through that in a simulation, thinking about before you actually run it, where people are going to be at in that space and how you're going to address that in the debrief means that you can address some of those, you know, this person was performing issues.
And I get the sense too that that's a little easier if you kind of know your learners, because you can probably even, you know, tease them a bit and call them out and stuff that you might not feel inclined to do if you've got a group that you haven't built up that trust with.
Right. I had a conversation with somebody just recently actually who was saying, you know, look, I'm going to start running some sims in this unit that's done a lot of mock code blues, and there's a lot of really anti-sim sentiment in that group. And I suggested to them, you know, maybe just run a few really basic, easy, you know, clear simulations first to get that relationship and that rapport established. You know, be really upfront about it. Like we just want to have a little bit of, you know, chance to practice a couple of skills. Is there anything in particular that you guys want to practice? Okay, let's give that a shot. You know, just really engaging with them, meeting with them where they're at in order to establish that relationship.
Yeah, absolutely. Well, we might see if there's any questions on Twitter relating to particularly this phase about psychological safety and actually delivering the scenario.
So definitely some endorsement of your idea that just stating that it's psychologically safe doesn't make it psychologically safe. And then there were a couple of questions about specific groups, and so introverted participants and consultants were the ones that keep coming
Two
up.
separate groups? Or?
As an introverted consultant, no. I think the consultant engagement can be really tricky, and for me that's another little yellow flag. If I go into a unit and they say, oh, the junior doctors are really excited about it and the registrars want you to get involved and the nursing staff are 100% on board, but we're not going to be able to get any consultants. And I think to myself, why is that? Is it the performance issue? You know, I'm going to be performing in front of my team and I can do that really comfortably in the clinical environment, but I feel uncomfortable about it in an environment that's not familiar. One of the most powerful simulations I ran recently was in a PICU, so testing out a PICU, and the director of the PICU came along to be the consultant, and during the procedure, which was, you know, night time, so not many staff around, he pressed the help button that notified the whole hospital that he needed help in the PICU. And I've got to say, that was one of the most powerful moments in simulation I've ever seen, because essentially by doing that, he was giving his junior staff permission to press the button to call for help. He was saying, you know, this baby is unwell enough that I need extra pairs of hands, and if the director of my unit needs extra pairs of hands, then I'm going to need extra pairs of hands overnight. And I just thought that was incredibly powerful. So I guess that doesn't answer the question of how to get consultants involved, but I think thinking about, you know, what are the barriers to them? Is it that performance issue? Is it, you know, being scared of the process? Is it being too busy? And I think that is a legit reason for some people. Is it that they have expectations of sim that isn't what we're going for? And I think it's worth pursuing the consultants, because that's a very powerful avenue of change.
Yeah. The other thing I would just sort of say in defence of introverts is I think we can let people engage with this with as much emotion and extroversion or not that they want to. Like I often see people trying to demand a feeling in the debriefing. Some people don't want to share their feelings, and I kind of think you do have to respect that. And an article that we did in the Journal Club recently about saving face, I think, is really relevant here. All right, well, the last thing I just wanted to talk about was debriefing, and that's nice, Q. Thank you very much, Ian. Yeah.
All above the table.
Yeah, above the table negotiation and debriefing. I love it. Yes.
Yeah.
Okay, talk about debriefing, and I'm trying to talk about it from the point of view of the providers. And I've certainly lived through an age where it's kind of like, oh my God, debriefing, it's so scary. Don't go there. You have to do a course. And then I watch people even after they've been to the course. Suddenly, it's this very constipated conversation where they're curious and they're wondering, and then they're kind of noticing, and I'm thinking, what the hell are you talking about?
I am now transitioning out of the reactions phase.
I know, yeah. So how do we help people go, sure, it is actually hard to do well. I'm not going to pretend that. But how do we let people also just take their great conversational skills and just use them?
Yeah. Well, again, I think that comes back to that me positioning myself as somebody who's interested and who, you know, wants to learn from you about what your experience was in there, because I was on the other side of the glass. Like, I didn't have that experience. And recently I sort of thought, maybe I should be doing more of these sims as a participant. Like, you know, even the junior doctor ones, to actually go in there and experience it as a participant, because it is a really different experience to watching somebody do something and thinking, why did you do that? That's really unusual. And again, I think, you know, when we come back to the right way to debrief, you can do almost anything in a debrief, and you can get away with a lot if you are genuinely curious. You know, if you do genuinely believe the best about people. So that was the first really transformative thing for me. And the second really transformative thing for me was that other bit about, you know, the debrief, in terms of they're there because they want to improve. So we can have difficult conversations with people because they're there because they want to improve. Now, sometimes they're there because they're told to be there. But if they're there because they want to improve, and the vast majority of them are, then they're willing to engage in those difficult conversations. So I can show them the respect of being another grown-up who's, you know, an experienced clinician for whatever level they are, sometimes a way more experienced clinician than me in another field of medicine, and actually ask them questions for my learning and for theirs.
Yeah, so it actually could be easier. Well, thank you, Cara. It's been a very edifying conversation. Just to give you an idea about how we're going, we've run our first couple of sessions with the junior doctors and with a range of the nurses as well. It's going well. Our evaluations are scoring us 10 out of 10.
Awesome.
But that's another podcast. So, on that note, ladies and gentlemen, that's Simulcast for this episode. Don't forget to come visit us at www.simulationpodcast.com. And on that note, thank you very much, Cara Allen.
Thank you, Vic.